Well, hello there, everyone, and welcome back to our debrief that we are doing at EULAR eCongress 2020. And when I say we, I am Tiffany. I am the CEO of the International Foundation for Autoimmune and Autoinflammatory Arthritis, or AiArthritis for short. Also a person living with non-radiographic AxSpA and a few others, which actually will come up later in this. And I'm not alone here. So let's say hi to Deb and Patrice. Deb, why don't you start off by telling everyone who you are?
Sure. I am Deb Constein. I am living in Madison, Wisconsin. I am a patient living with RA. I was diagnosed at the age of 13. So I've actually had quite a journey with that disease, as well as a few other comorbidities. I am a dietitian by trade, and that's where piques my interest with all of the science and research, and love getting my fingers into all this stuff. So I like to be part of this group that we have.
Yeah. Okay.
Yeah.
And Patrice, hi there.
Hi, I'm Patrice Johnson, and I'm coming to you from Northern California. I have had RA or something along those lines for 9 years, and like Deb and a lot of us, I have a few comorbidities. This is my first time attending this type of conference, and it's on the scientific side, but on the other hand, it's just expanded my knowledge of diseases and what the researchers and people are working on. So it's been quite a learning experience for me, and it's such a wonderful journey. So thank you for having me.
That's awesome. That's awesome to add there. And so a little background just on that before we get into this. So first of all, what are we doing? And a little expansion on what Patrice just said. So EULAR stands for the European League Against Rheumatism, and they are the lead rheumatology group in Europe, and their partners in the United States would be equivalent to the American College of Rheumatology, or the ACR. So every year, our organization attends both of their scientific conventions. So one is typically in June, the other one is typically in November. So, you know, you've got each half of the year, and all of the latest research and treatment protocols and guidelines and resources for rheumatologists to give to their patients are revealed, and it's really driven for rheumatologists and researchers to be able to advance the profession of rheumatology. Only recently have patients been invited to attend on different levels. Now, not so much in the ACR yet. You'll hear more about that on some of our other debriefs. But at EULAR in particular, they have three pillars. They have a pillar that's for the research community. They have a pillar that's for healthcare professionals. And then they have a third pillar that is for patients, and that also includes nonprofit organizations. So that's the one place that the ACR does not have. They don't have that third pillar. And saying that, the conference was supposed to be in Frankfurt, Germany. If you're wondering what's behind me, that would be me simulating myself, because the people aren't walking, so you can tell that it's not real, unless they're looking for a real long time over there. But when we go to the sessions, usually afterwards, we will go and have lunch or dinner, and we will do what's called a debrief. And that is going talking about all of the research that in all the sessions that we just attended during that day. So this is our debrief, and one of the things that you are invited to do this, or opened it up for people to do this year, since it was canceled, the physical conference due to COVID-19, for the first time ever, the scientific conferences in the rheumatology community is online. And so they opened up all of the access to see everything available at the conference. That's usually 4 days. That Deb and I are running around trying to get everything in 4 days. They've spread it out to September 1st. And as people living with these diseases, we thought two things. A, well, why should we rush and try to get through this in 4 days? In FLAIR, why don't we take our time, divide it up, and really learn and soak it all in? And then two, why not invite everyone else to come with us?
Yes,
so,
exactly.
I mean, why not? Our mission as an organization is to help other patients like ourselves have a voice as equals alongside all the other stakeholders in the rheumatology community, so we can solve problems that will impact education, advocacy, and research. So this just seemed like a great opportunity. We always like to say, we learn, you learn. Now, here we are. And what Patrice had mentioned is that she is coming for the first time. And that's really, I think, great to say, because we're inviting everyone in the community, patients who've always maybe been interested in these scientific sessions, but maybe they are very advanced. They are difficult to follow in some cases, but there's a lot you can learn, like Patrice said. And Deb and I may be old pros at this, but Patrice has come along for the ride, and she's living testimony that she's learning a lot, and I think you all can too. So I don't know, Deb, if you wanted to add anything to that.
Yeah, I just think it's, I remember being back in Patrice's shoes, sitting in the first meetings, the first times, and going, whew.
Yeah.
But again, what's been nice, when Tiffany and I, sometimes we attend the same sessions together. I'm taking pictures, the screenshots of the slides as they go. Tiffany's taking notes, but we also are, if there's something that we don't know, we've got our phones that we're quickly Googling, terminology that it's like, all those aha moments. So,
right.
Yeah, it's great. And Tiffany, I mean, our debriefs are any meal that we have, we're sitting there talking about what we've learned and what we can bring back to all of you, so you guys can learn with us. So yeah, and just everything that applies to our mission. So it's great, and it's we also have fun too, but it is a lot of work while we're there.
Right. So here we are, we're on our last debrief. So all through June, the three of us have been attending sessions that we felt were most relevant to our mission. And then we have them all reported back on Thursday. So if you haven't seen the other debriefs, you can go and look at those here on YouTube as well. And then after this week, we're going to then invite everybody to come along with us. We're going to focus in on some of the hottest topics that I just jiggled that all over the place. Some of the hottest topics that we have covered, and we're going to invite you to the conversation. And so we'll tell you a little bit about that at the end, but we're going to jump right in here. So this last week, a lot of it was focused on treatments. We saved the disease-specific sessions for last. And one of the themes that we have had come up over and over and over again from day one was treat to target. And also treat to target. In the first sessions that we reviewed, it was also about remission or when to stop a treatment. Like that was the first time we had ever even seen that at a scientific convention. So that one, all of this is kind of wrapped in this theme of treat to target. What does that mean now versus what it meant before? What we're finding is it's tying, what it used to be was really trying for early intervention in order to create that remission or have better outcomes. Now that sort of shifted into how do we treat to target for complex diseases, which all of ours are, and they're recognizing that all of ours are. So that's going to tie back to some of our other debriefs. So this treat to target, I'm going to start first with Still's disease. So Still's disease is a disease that they talked about having, it was called the Still's spectrum. So I'll start with that. Historically, Still's has had, you have adult onset, so it can have an adult, but then there's also juvenile onset. And that onset has caused over time quite a bit of confusion in rheumatology circles at hospitals, because Still's is a rare disease and it's not well understood. One of the biggest issues is that the systemic version of juvenile idiopathic arthritis, which used to be called juvenile rheumatoid arthritis, so the systemic version of that is Still's disease. So that is different than juvenile idiopathic arthritis, but it still has arthritis in it, and it had rheumatoid in it early on, right? So there has been a stigma that the Stills population has been dealing with for quite a while, that it's a subset of rheumatoid arthritis. Okay, so in that we just know because of our work as an organization, that's not what we learned here. I'm just giving you a backdrop. So as far as where they started here, they were talking about the need to really start to group these two together. Right now, there's a lot of registries that are either for adult onset or for juvenile. And yes, there are definitely some challenges, whether you have an adult onset versus young onset, and that can't be ignored. But what they were finding in the research that they were showing is the gene expressions that they are finding that they are the same, whether you are a child or whether you are an adult. And what that says is that Stills is actually the same etiology, the same disease, regardless of the spectrum. So that's why we're using it as sort of the umbrella term, Stills disease, even though there are those branches. And saying that, there's also other branches that they talked about in the adult onset Stills community, where maybe you have one time you have onset, maybe there's different versions even within that. And I think that's really important to note, because it falls into another theme, precision medicine. And that's really where Treat to Target is going now. So we started with the whole philosophy that if you go and get treatment early, you have better outcomes. That's been proven. Been proven. And so now they're saying, well, we need to understand these diseases in their entirety, and especially in the specifics. Sometimes that has to do with the genetics and the symptom studies, but to make sure that we are understanding exactly how to treat these for the individual patient. And that is something that our organization has been a champion of for several years. We are proud to say we have been in the forefront, and we can say that because we've been told by many pharmaceutical companies that nobody was doing what we've been doing for precision medicine. We were the only ones for a couple years. So shout out to us on that. The reason we were is because we as patients talking to each other realized that we are complex and we do need personalized treatments, because we are not a one size fits all. And so that's why a lot of the work that we do. So there is no doubt about that. So essentially they were talking about the need to recognize Stills as the continuum, to really start working on registries that combine the two. Personalized medicine is when you treat to your personal needs, precision medicine treating to the biology of your disease. So they're really working on the precision medicine part, but we as an organization also the personalized, because we believe a holistic roundabout treatment. So I wanted to put that in there as well. One of the things I found really interesting about this is they talked about the arthritis. And we've known that not all patients present with arthritis. And the last I had heard, it was 25%. Now they quoted it as 50%. So I'm going to look into that a little bit more. That seemed high to me, especially the research we've personally done. We had an early symptoms of Stills disease. Early symptoms of AiArthritis project in 2000. We published in 2015, and Stills was one of the diseases. And in our research, which had 68 patients in it, over 75% said that joint pain was in their first. So that would fall under the 25% that's not, right? So that seemed in keeping. So this 50 seems a little high, but we'll look into that more. The reason that I'm pointing that out is because they also talked about they showed all of these different classifications and criterias. So unlike some of the other diseases, there's a lot, there's like, I think there were 5, don't hold me to that, but there were different criteria for diagnosing still. Some of them had arthritis in there as a main, some of them didn't. And so they are calling for one set. And I think that makes complete sense. Because how can you possibly diagnose a disease when there's different criteria?
Right.
Talk about confusion.
Yeah.
I mean,
Very.
so that's something that they're moving forward to, and we will definitely be following up on that. But the other thing just to note was that they talked about in these biomarkers and treatments, in particular the IL-18s. And that's really referring to different biologics that target something specific in the body. And they keep coming back with research showing that the IL-18s are very effective. So that's good news. And we will continue, that's great news. And so we will continue forward on that as well. But
and Tiffany,
go ahead.
Didn't they just also release the first medication for stills just
in the United States?
Yeah.
Now their Kineret has been approved for stills in Europe for some time. And I know there's patients that are not in Europe that use it. There's a lot. EULAR was just a few weeks ago by the FDA approved for adult onset Still's disease in the United States. So that's the first one approved here.
Yeah.
And here meaning in the United States. But we follow internationally. So there has been progress. Oh, and I'm glad that you brought that up because there was one more thing that I wanted to add there. I don't know where this is on my piece of paper, but I couldn't find it the other night either when we were talking about it.
But what's funny is that all three of us have our pads of paper. We're all three paper people.
Here it is, found it. Okay.
Good. I gave you that little bit of window.
So because of this was really important, I almost missed, well, I would have found it later on and we would have circled back. But this is the last thing I'll mention about this session. The research into the gene expression showing that there is a continuum between systemic JIA and adult onset being AKA Still's disease, that the EMA, which is the European Medicines Agency, they are the agency in Europe that regulates the use, which is what we just said, the FDA, the Food Drug Administration in the United States approved that drug for Still's here. So the EMA changed their treatment recommendations based on that information that there is a similar gene expression, and they've changed their approval of a drug that was only indicated for systemic JIA and changed it to Still's disease, parentheses, SJIA and AOSD. So that means that they have recognized same disease and its pathology, and because of that, the regulatory approval is based on, hey, if it worked in systemic JIA, then it's only going to say to be true to work in the other. So that's big. That's really big. So I am going to pass it over now, I think, to Patrice. Talk a little bit about lupus.
Right.
Yes, the session was called Advances in Lupus Treatment, and there were several sessions. I personally don't know very much about this disease, but I do have a friend that does have this disease. And they were actually saying that it's difficult to treat lupus, treat to target for lupus patients. And they are retargeting existing medications. And the other thing they were saying was, they talked a lot about remission, but what's the definition of remission? So, that's, I guess, something that they're eventually going to probably discuss further on down the line.
Yeah, we all had a conversation about what that definition is. So, or what, all the different definitions of remission are across the
Yeah,
board.
yeah. I mean, I do pretty good on my medication. So am I? I mean, I don't have lupus, but so am I in remission? I don't know.
I know.
Well,
Yeah.
I'm gonna, first of all, let's give a shout out to Susie, because
Yes,
she
Yes.
is part of
Yep.
our
Palmer, we love
extended,
you.
she is part of our extended crew that's attending EULAR. So you've seen the three of us, we're sort of we're calling ourselves the core because we've been going to all the sessions, but we also have an extended team who's going to come on board here in July. And Susie came on board a little early, and she helped us because she has lupus and helped us review the session. So we want to give a shout out
for over 50 years.
Yes.
So you got to give a shout out.
To it. Yeah.
Yes. And didn't she say the other night when we were talking to her that her father just handed her this book? What's it called? The Merck
Manual. It's called the Merck Manual, which is
Here, you have lupus. Read this.
at the age of 13.
I know.
Yeah, because
I can't even imagine.
Very scientific family with doctors and all that. So kind of just tossed her the Merck Manual.
Yeah, and she did this amazing job of typing up all of these notes for us. So look at that.
I know.
That's amazing.
Thank you. Again, nobody knows it better than the expert who actually has it. So
correct. So thank you, Susie. So
yes.
And then
go ahead.
They went into JAK inhibitors in systemic lupus, and but there was no audio, so it was more of a lot of slides that yes. So it was, that one was kind of difficult to follow. And then the last one was called Lupus Comprehensive Disease Control in SLE Patients. And they did define 3 types of remission, which it's kind of very clinical, but so that was pretty much the whole session. And like I said, I'm no expert in this disease, and but it's very interesting because, like I said, Susie is a friend of mine, and understanding what she, I mean, for 50 years has been going through, very different than what I go through. So,
one of the things too that to expand on that, first of all, JAK inhibitors, again, it's just that they're a big theme here at this conference. It seems they're being tested in everything, and in some of them we're finding that they're more recently being tested, so there's not data yet, which is in this case. There's not a lot of data, and same with the stills. There just isn't enough, but they have been tested earlier in psoriatic arthritis and rheumatoid arthritis. We know they have shown in research to be equally as effective as some of the other biologics. So they're sort of the eye on the JAK inhibitors. You're seeing them everywhere.
EULAR, it's been like we've been identifying themes throughout our conversations, and you'll also hear themes as we've been talking over these 4 debriefs. So you'll definitely see those.
Yes, and I'll just very quickly add, they did show some results of Benlysta, and that is indicated for lupus. There's not many treatments out there, and so this was a biologic that was approved a few years back, and this was a literature review for the most part, but the results were that it does increase the probability of remission, but we're throwing that word out there again. What that means to us is a little bit, there's clinical remission, and then there's complete remission, which is no disease activity at all, and and our version of remission. So I don't know what you call that, but that could be a little bit different. So they were giving us some updates on how Benlysta's doing, and we'll be able to put some information together more for you on that. And then these treat to targets again, and they're going into these IL-12 and 23, and again that means that it's a specific target. So the ILs, in addition to JAK, are getting a lot of traction.
Yes,
a lot of attention
in this. And then the other thing was multi-targeted therapy. I'm sorry, let me go back. The targeted ILs, we can reach out to our friends at the Lupus Research Alliance. I see their name right here. So LRA, shout out. Hey, Diane. Woo, holla. So,
Yeah.
and ask them for a little bit more information about that, because it says that they did a study on that. So we will reach out to them. And then as far as multi-targeted treatment, it's just something we keep seeing again. These are complex diseases. One size isn't going to fit all. One treatment may not fit all, especially in complexity. So we're following that research as well. So a lot happening for lupus. That is positive. It's just it is a very complex disease, but there is a lot in the funnel for it. So we will be keeping you abreast on that as well. And then Deb, you want to take it over for?
Yeah. So I actually did a Sjogren's session, and again, that is a disease that I don't know a ton about, but it was actually, we followed lots of themes that went along with that as well. So it talked about personalized medicine. It talked about the complexity of that disease as well.
Or precision medicine, right? You said personalized.
No, personalized. No, it was personalized.
Oh, it was personalized.
That was personalized medicine. Yeah, that one was personalized, because I actually wrote that down.
Okay.
And that they are trying to break the patients down into 3 subtypes. And within clinical practice, they were breaking it down into systemic activity, risk of lymphoma, and low risk patients. So they were kind of lumping patients into 3 different subgroups. And they also broke the categories of the medications down into interferon types 1 and 2, T cells, B cells, and plasma cells. So again, those were the overarching themes, and there were different studies that were done within the different pieces of that session. But those are the kind of the overarching themes that were going along with, again, another very complex disease. So,
and actually you found that too with the behcets, right, Patrice? We'll just jump on to that and just throw it out real quick. I mean, that was just the theme.
Yeah, they said personalized treatment that they're working on. That was too. I didn't take a lot of notes because I just listened in. Yeah, another one of these. I knew nothing about this disease. I'd heard the name, the term thrown out a couple of times here and there, but kind of didn't really pay any attention to it until I watched this. So yeah, it was very interesting, and another very, very complex disease. I learned how to pronounce the name.
Well, I'm familiar with behcet's because I have that actually on my chart as a diagnosis. Now, I don't meet the clinical guidelines because I'm missing the inflammation in the eye.
uveitis, didn't you say uveitis? Didn't you say that?
Yeah, it's anterior, so there's different.
Oh, okay.
Yeah, I don't have that, and that's the only thing that I don't meet. So, but it's still on my record because Deb has witnessed the severe canker sores that I get in my mouth, and it's terrible. And so, my rheumatologist said we're going to treat it like it is and see if it works, and the treatment's working. So we're just going with that.
Stick with it.
But it is a very, again, complex disease. And we're seeing that is a common theme, that our diseases are being recognized as complex. And that includes rheumatoid arthritis, that includes psoriatic arthritis. So I like seeing the diseases that are under our umbrella being recognized together as complex, as need for individualized therapies. And I just think that's really, really huge. And then as a side note, our organization can really follow up on the behcet's disease in more detail for 2 reasons. First of all, Murda, holla. So at the American Behcet's Disease Association is a dear friend of ours. And so we can certainly follow up there. And say, forgot, with Sjogren's, we can follow up with the Sjogren's Syndrome Foundation as well. So holla to them. And I am also, Deb is as well, but part of OMERAC, which is outcome measures in rheumatology. And I was part of sitting in on the Behcet's disease working group at the 2018 meeting. So there's a lot of background information that we are privy to as far as what's happening in research. So we are following up on all of these diseases, and we just wanted to make sure that you knew that these are being studied. and they're really focusing on those individual biomarkers and how we can target multi facets of these very complex conditions. So I think that's all we wanted to really wrap up on the disease.
The rheumatoid one.
Right, but that was about surgery though,
Yes.
right? Yes.
Yeah.
So we're going to move on to that one next.
I thought you were ready to like wrap up. No, we're not done yet.
No. It's just a little. That's why I threw behcets in, even though we have like an order here that we were going to go in, but it just made more sense to throw that in while we were talking about the other treatments. So okay.
Absolutely. So you're ready to jump into that one? Oh, sure. So you're like, yes, I'm waiting now. So the session I actually went to was, it was based on joint replacements and things like that, and just overarching principles that went along with that. And the prosthetic joint infections and things like that within RA. And it was only very specific to RA. And, as far as like a overall summary from the session, it was that RA, you have a definite higher risk for prosthetic joint infections, or, needing to have them revised or having new joints put in because of, infections and things like that. And it talked about that very specifically. And they talked about suspicion from other infections from Staph aureus and things like that could actually be an underlying thing as well. They talked about pre-op optimization. So that was actually really interesting. They recommended that pre-op you have cervical spine disease screening, that the immunosuppressant and glucocorticoids, so that's like steroids that you might be taking, that they may contribute to part of the risk, but you need to leave them alone. You don't decrease or anything like that prior to surgery, otherwise the patient will have even worse flare than they typically do anyways after surgery. They also talked about if you had multiple comorbidities, like if you were a smoker, or you had a very high BMI, so you have a higher weight than is your optimal weight, that those things would be contributing factors. And it was amazing because the study they did, that if you added just one of them, like if you were a smoker and had RA, that your chance of having a issue after surgery, it was significant. I don't remember the percentages, but with each additional comorbidity, whether it was your BMI, smoking, RA, and like all of the several of them, it just skyrocketed the percentage of chances of having these type of infections.
Complication. That's really interesting, because that's not unsimilar to what we heard in the COVID.
Yeah, that's absolutely true.
Just saying. I mean, we've been hearing that over and over, that a person's comorbidities increase the likelihood of complications. And so I just wanted to throw that parallel in, because as I'm listening you talk, I'm thinking, wow, well that's
that before.
But the other thing you were saying the other day too, Deb, is that the whole methotrexate thing.
I was gonna get into that next. They talked about wound healing, and they said that methotrexate, there are fewer wound complications and infections and flares in RA if you are continuing your methotrexate even during your surgery. So for me, having RA over years, and I've had knee replacements, my cervical neck fusions twice, wrist fusions, foot surgeries, all of that, they've always stopped the methotrexate prior to surgery. They've always stopped any type of biologic I was on, and they've always taken my anti-inflammatories away. prior to surgery. So your chances of actually having flares after, even before surgery, you start having flares because you're without your medications. So this surgery I just had back in November was the very first time, and they even said this may be different for you, and it was, because because they normally go through a couple weeks before all the different things you need to do and when you need to stop your medications and all of that, and that's typical protocol. Well, this time they're like, yeah, with your methotrexate, you can continue your methotrexate. They're finding that you will have a better outcome. And I had actually a great outcome in this surgery, even after with continuing that. And my flare wasn't as bad as it has been in the past. Because you always hate to be after the surgery and being without your medications due to these surgeries. I mean, that's usually kind of almost the worst part of it, of just knowing that that was coming. So yeah, just even from my own personal experience, it's interesting. And
that's really cool. We're going to have to, we'll have to circle back and find out who the researchers were on there and share your story with them.
Yeah. I'm perfect example of.
I watched your session and I'm only proof. I mean, that's kind of cool. That would be cool, I think.
Yes, exactly. And they talked about all of the other, like, for instance, hand surgeries. There was no difference in the DMARDs, which is like methotrexate, and your the different kinds of anti-inflammatories. Foot surgery, no increase in complications linked to the medications either, which again is very interesting. And again, I'm perfect example of this being successful. One other thing they did talk about was within 6 weeks after having your surgery, they say that, you're going to have post-op flares. They're frequent because of being without. They said that more patients after stopping your biologics, they flared, and it's not necessarily independent predicting of the flaring itself. So, it's really interesting. You're without your medication. So, I mean, I can't imagine. I mean, I'm a perfect example of all of those too, because I've had all those with my previous surgeries. It's tough, and they sometimes they don't give you your medications back for up to 6 weeks after your surgery. So not only are you going through surgical pain, but you're also flaring like crazy because you're without your medications that you had when you were in actually fairly decent control. So great session.
That will be a great follow-up conversation that we'll have to have, because that is just a really relevant point you just made, thinking about stopping treatments, and then you've got you're inflamed from surgery, and then on top of it, I have not had surgery due to my condition, so I don't have the personal experience, but that is certainly a topic that I think needs to be further explored. And I definitely think patients need to be privy to the fact that, wow, guess what? I could still be on something. Now, for me, that would be interesting because I'm not on methotrexate.
Yeah.
I'm only on biologics. So, that's just something to look into as well. Like the people who don't take methotrexate, is there an alternative? So anyway. But that was great. Thanks.
No, it'll be interesting to actually talk to patients when we, bring everybody to the table when we're talking about this, and ask them about, hey, for those who have had RA and have had it for a number of years, who have had, joint destruction that they're trying to fix, what have your experiences been with surgeries? What medications have you had to stop, and has that changed? Has anybody had recent surgeries that have been different?
Yeah, I think hearing from the patient voice in this topic can maybe be very relevant to future research in
absolutely
how to manage this. So we'll definitely have to follow up on that. And then speaking of following up, first of all, we're done with our list, right?
Yes.
Second. Okay.
EXPA.
So
have a little bit to do on EXPA.
Oh, see, I did. I forgot.
Your other one.
I'm having some brain fog today. I can tell you that. And we're doing this later in the day than we usually do. And this is my key brain fog time. So thanks for keeping me on the up and up. Well, it's a short one. The last one was treat to target for AxSpa, which is Axial Spondyloarthritis. And that is my main diagnosis. As I said, we also have behcet's on, but this is my primary. And originally rheumatoid arthritis, but then switched in 2013 when there was such a thing as non-radiographic AxSpa, because there was no such thing prior. Anyway, it was again treat to target. It was right in the name of the session. So I mean, if we can't drill home any other theme than what's happening in research, it's treating the target that has moved from treating early, which is already demonstrated that research has already demonstrated that treating early leads to better outcomes. Just that's the conclusions they're giving us now. Now they're taking it to the next level, and everything is about how do we treat to these complexities of the diseases. And really what this one was about, they focused on a study that, I'll give another holler from UCB, pharmaceutical company. Holla to UCB. So it was a research that was funded by them. So we like to point out that pharmaceutical companies are also doing great work when it comes to these types of trials and figuring out what is going to work best for patients. So I know a lot of people see the pharmaceutical companies from one end, but behind the scenes, there's a lot going on that they do. And
they're friends of ours. I mean, seriously, they are friends of ours.
Extremely supportive in the work that we do, and we are very supportive in this type of research. So they're looking into treat to targets for this disease. So just wanted to give a shout out to all of the stakeholders. Going to do that too. So one of the things that they realized is with AxSpa, which is Axial Spondyloarthritis. Again, umbrella term. We got a theme going on there too. We talked about Still's disease as an umbrella term. So, and I had said I was originally rheumatoid arthritis. So what happened was ankylosing spondylitis has always been the disease that people have known. And that says that there is an issue with, usually it's characterized with the lower spine as part of its spondy. And up until a few years ago, it was taking, oh my gosh, 6, 7, 8, 9 longer years. It was one of the highest for diagnostic time. And by the time patients are getting diagnosed, it's like kind of too late to really intervene and ever achieve remission. So the treat to target becoming very important for this disease. Now, what happens, it makes it a little complex, is that it was realized that it was taking so long, and part of it was because of a lack of radiographic imaging. And so there was
X-rays. So those are the X-rays we're talking about.
Yes. Radio, or MRIs, or just nothing showing. And so a lot of patients were not getting diagnosed. And so there is essentially two legs that have come out of this, and you have non-radiographic, and then you have it's radiographic, but they're not calling it radiographic axial spondyloarthritis. It's still that would be under the category of ankylosing spondylitis. So I, as a person who do not have the evidence on the radiographics, it doesn't mean that my disease or what I'm experiencing is any lesser. So that has been recognized. And the problem with treating to target, when you're thinking of that perspective or that continuum, let's say, where you've got some patients who have no radiographic evidence, and then you have some patients that have radiographic evidence. At some point, all patients were non-radiographic.
Yeah.
At some point, they were all. I mean, because it took time, like my little.
To get there.
I'm watching myself on to make sure I'm going the right direction. like a weather reporter. And so it's hard to identify early disease in this particular group, because this trial that they did, it was early. The patients could not have had more than 2 doses of NSAIDs, which is like a ibuprofen or that along those lines. And biologic naive. So we're talking early. And so there was a big issue that it's hard to measure a radiographic damage when early you're not having the radiographic. So that's just one, I guess, an obvious. But the interesting thing for me was that they were trying to show what usual care is versus treat to target, since there's such an issue with treat to target in this subset. And the flaw, and this is another thing that came up, was bias. And we've been seeing a lot of focus, I think, ever since COVID and research. There's just a theme now of biases, and that means there's something about the research that could pull it one direction or another, in favor or not in favor, because there's it's not equal in some way. So that's what the bias is. And in this case, they did the study where the usual care was given by people in a facility that were experts in spondyloarthritis. So they didn't find, not surprising, there was not a statistical difference between usual care and treat to target, but they did find that there was a reduction in costs. And that's another thing that we've seen here. They're focusing a lot on reducing costs. So there was a reduction in cost, even with the implementation of biologic use. So that shows that the argument of using biologics early are going to inflate the healthcare system. Not really, because if you're treating early and then you can go off of them at some point, you're not lifelong. You're not on that lifelong path that's going to eat up the healthcare costs long term. But I would love to see a study where they go to a random rheumatologist's offices that are not specialized in spondyloarthritis and do a similar study, because if usual care and treat to target, or maybe usual care and treat to target does have to be the same, which is the other underlying takeaway here, is it might have to be the same, because it's early disease is early disease, and you're going to treat non-radiographic the same you're going to treat radiographic. And that's kind of, so that was the point of it. So it's a really interesting one, because we've been talking about these treat to targets for all of these diseases, and then you've got this one where everybody starts the same in this one category. So so that was just, as a person living with it, that was extremely, that was of interest to me. And then they ended by saying, to truly do this do therapy on spondyloarthritis patients, it has to be individualized and strongly dependent on the healthcare system.
Well, individualized. Hello.
Individualized. And when they talk about the healthcare system, they're saying, but depending on where you live in the world, having access to treatments is obviously going to depend on how you're treated, right? Because if you get treatment XYZ because your healthcare system is saying, no, you need this instead, then that's a factor as well. But so that was the big takeaway there. So thanks, Deb, for not letting me forget my own disease.
Yes, I know. I wasn't going to let you do
this. Okay, so now we're done, right, Deb?
I think we are. Yep.
Yes.
That was it. Yep.
Okay.
So again, I mean, you guys can see that we are like doing a lot of, hopping around in different sessions, and how much we're learning and bringing back the state of the art, the newest information to you guys. Mm-hmm. So that's, that is what we are doing, is, we're learning and disseminating and feeding it back to you guys, so you guys can actually be part of these conversations and, our aha moments and themes that we've been taking away. So love it.
Absolutely. And it's just a really good example when people say, what does your organization do? What do you do? I mean, we've already set our mission statement, you know, our whole mission of being people living with these diseases and making sure we're equals at the table with the other stakeholders to solve problems. But this is a proof of why we need to be at the table, because by talking to each other and including all of you, all of other people who are living with diseases from around the world, only when we keep talking to each other can we connect the dots. Because you can see, if you watched any of these debriefs, we have aha moments between just 3. Yeah. So imagine if there are 3,000. I mean, the amount of information by just having us with lived experience to be able
who is
to figure
the
out problems.
Yeah, who are the
we
experts?
are.
Yeah, exactly, Patrice. We are. And, you know, we have the lived experiences. You know, it's one thing for a researcher or for a doctor to say, I think this is important for the patient. Well, who knows what's important to the patient unless they ask us.
Right. And the other part of that is we have just realized that patients hold the key to figuring out those missing connections. So nobody can fill in those blanks but us. And so those are the kind of things that transpire out of conversations. And in speaking of that, we want to invite you to come with us. So the next phase of this, we have 4 debriefs now that are on YouTube, and they cover 5 to 6-ish sessions that we've watched throughout the week. And from those, we are now going to be narrowing it down and to these hotter topics. And you've heard some of these themes that have come about. And that's how we're basing the next 4 conversations that will be live on YouTube at 7 p.m. Eastern Standard Time on Tuesdays throughout July, starting on July 7th, and then again every Tuesday. Now, if you say, well, I can't be on there live, that's okay. Of course, we would love to talk to you live, but YouTube isn't going anywhere, and neither are the comments. So you can always feel free to come back and add to the comments, and the conversation doesn't have to end just because our live conversation ends. So it will be there for you to talk to us. Now, in saying that, those topics are going to fall under treat to target, precision medicine, COVID. We had a lot on COVID early on.
Oh my gosh,
remission and adherence to treatments. There was one in particular that it wasn't a theme, but it was so powerful, and that was pain.
Yeah.
Oh yes, I remember that.
That one
about the brain.
That was just a really great one. Is it all talked about the mind and body connection in pain. So we're definitely going to include that as one, even though it wasn't a repetitive theme.
Yeah, it wasn't a standalone, you know, I mean, or it kind of was a standalone because it just stood out to all 3 of us in such a way of how it was so powerful.
Yes. So we will have a list we will be finalizing that list for you, and so that people know which topics we'll be talking about each of the weeks. But if you want to make sure that you get a copy of that, you need to register to go with us. And so if you go to our website, which is AiArthritis.org, right on the home page, there's a slider of photos, and one of them has our smiling faces and says, go with us. I think it does. It says, go with us, and click on that, and then it just captures basically your email and your name and your country, and then we will provide you with updates not only on what those public, but we are launching finally our AiArthritis Voices online platform only for people living with the diseases, and we will be having a private activity page, which is like a group in there for people who have signed up to go with us. So inside that group throughout August, we will be also talking about some research reviews, maybe some posters or abstracts that we've seen. You can ask more questions about all of the debriefs, and we'll be in that group and available to talk, plus our extended team, and we'll have some fun reviews and encourage German food and fare. And we'll teach you all about what it's like to join a conference, share some behind the scenes footage of some that we've been to in the past, and good old fun. So just come and join us if you'd like that as well. I think I've covered everything.
Yeah, you know, the only other thing I would just say is, if you guys are listening to what we are talking about and you're thinking to yourself, that happened to me, or, you know, that kind of stuff, we want to hear that from you guys. So please share your comments, your feedback. You know, we're talking about, you know, all of our scope of inflammatory diseases. So we're covering lots of different areas that you are the expert of that disease that you have. So, you know, share that with us. We want to connect those dots and have you have a seat at our table collectively.
Yes.
So,
and
yes.
you can do that by commenting on this YouTube post, or if you would like that to be private, you can also email us at info@aiarthritis.org, and we'll be happy to collect your input that way. Or you can find us anywhere on the social media platforms, which is AiArthritis. You can message us there too. So that's it.
Yeah.
We're wrapping up our debriefs, and we're moving on to the lives to join us at EULAR 2020. So
Can't
sign
wait
out.
to meet you guys. Yes.
We'll see you there.
We will see you there.